Welcome everyone for Module 3 of the Comparative Neuroanatomy Educational course that organized by the Yemeni Society of Neurosurgery and in collaboration with the World Federation of Neurosurgeons, Young Neurosurgery Forum, and Pakistan Society of Neurosurgeons, along with the Neurosurgical Couch and Neurosurgical TV. Today we have our first webinar of the Module 3 that will be focused on infratentorial anatomy of brainstem and cranial nerves. Our first presentation will be with Dr. Nargiza Saatova, a neurosurgeon from Uzbekistan. She is trained in India at Krishna Institute of Medical Science and her professor Algerian, and also trained in Turkey, Istanbul, and in USA, Florida, at Orlando Health Hospital with Professor Samir El-Baba. Dr. Nargiza, how are you?
Hello, everyone. Thank you for the invitation. It's a great pleasure to start the comprehensive neuroanatomy knowledge course. And I think I can share my screen, right?
Yes, please.
Mm-hmm. Okay. So today I will be talking about briefly about infratentorial space. 1 second. And so tentorium cerebelli divides the cranial cavity into 2 compartments. Basically, it's supratentorial and infratentorial compartments. Infratentorial area contains cerebellum, brainstem, cerebral aqueduct, fourth ventricle, and CSF systems. They are all connected with each other with neurovascular structures. Cerebellum, the anatomy of cerebellum is quite complicated, but we have to mention that cerebellum consists of vermis, 2 lateral hemispheres, superior, middle, and inferior cerebellar peduncles, which are connected to the superior cerebellar peduncles, connected to the midbrain, middle cerebellar peduncle connected to the pons, and inferior cerebellar peduncle connected to the medulla. The cerebellar cortex is divided into 9 zones, superinferiorly. Each segment consists of a segment in the vermis and 2 lateral lobes in the hemispheres. Also, it contains cerebellar tonsils, nodule, and the flocculus. 3 neurovascular complexes. The upper complex include superior cerebellar artery, midbrain, cerebellum mesencephalic fissure, superior cerebellar peduncle, tentorial surface of the cerebellum, the oculomotor nerve, trochlear and trigeminal, 3rd, 1st, and 5th nerves. The superior cerebellar artery arises in front of the midbrain, passes below the oculomotor and the 4th nerves, above the trigeminal nerve to reach the cerebellum mesencephalic fissure, where it runs on the superior cerebellar peduncle and terminates by supplying the tentorial surface of the cerebellum. Then we have middle complex, which includes ICA, anterior inferior cerebellar artery, pons, middle cerebellar peduncle, cerebellar pontine fissure, petrosal surface of the cerebellum, and the 6 nerves, 7 and 8 nerves. The ICA arises at the pontine level, courses in the relationship to the 6 and 7 and 8 nerves to reach the surface of the middle cerebellar peduncle, where it courses along the cerebellar pontine fissure, terminates by supplying the petrosal surface of the cerebellum. And then we have the lower complex, which includes the pica, medulla, inferior cerebellar peduncle, cerebellar medullary fissure, suboccipital surface of the cerebellum, and glossopharyngeal, vagus, spinal accessory, and hypoglossal nerves, lower cranial nerves. The pica arises at the medullary level, encircles the medulla, passing in relationship to the glossopharyngeal, vagus, and accessory and hypoglossal nerve to reach the surface of the inferior cerebellar peduncle, where it dips into the cerebellar medullary fissure and terminates by the supplying the suboccipital surface of the cerebellum. When we talk about the brainstem, we have to say the brainstem and the ventricle floor are considered together because the brainstem forms the fourth ventricle floor. The brainstem in the posterior fossa is composed of mesencephalum, which has the cerebellar peduncles, tectum, and tegmentum. Pons, which is continuous from each side with the middle cerebellar peduncles, and medulla, which contains the medullary pyramids and olives. The floor has the superior or pontine part, intermediate or junctional part, and inferior or medullary part. So here you can emphasize the pictures of Roten atlas. The fourth ventricle is a broad tent-shaped midline cavity located between the cerebellum and the brainstem. It is connected rostrally through the aqueduct with the third ventricle, caudally through the foramen of Magendie with the cisterna magna, and laterally through the foramen of Yushka with the cerebellopontine angles. Most of the cranial nerves arise near its floor. It has a roof, floor, and two lateral bracts. It is ventral to the cerebellum, dorsal to the pons, and medial to the cerebellar peduncles. The vascular relationship, each wall of the fourth ventricle has surgically important arterial relationship. The superior cerebellar artery is intimately related to the superior half of the roof. The pica is intimately related to the inferior half of the roof. The ICA is intimately related to the lateral recess of the foramen of Yushka. Basilateral and vertebral arteries give rise to many perforating branches that reach the floor of the fourth ventricle. The choroidal branches of the ICA supply the portion of the choroid plexus in cerebellopontine angle and adjacent part of the lateral recess. And the pica supplies the choroid plexus in the roof, the medial part, and the lateral recess. Cerebellar aqueduct, it's one of the narrowest neurosurgical structure, anatomical structure in our brain. It is narrow communication between third and fourth ventricle, surrounded by the periaqueductal gray matter, with the tectum of the midbrain located posteriorly and the tegmentum anteriorly. Roughly, it's about 1-2 millimeter in diameter. It has pars anterior, antrum, and pars posterior. When we talk about cerebral aqueduct, we have to mention that it do have very important clinical importance, and you even can get the access to the cerebral aqueduct through the endoscopic surgery. When there is something called, when there is clinical presentation called trapped fourth ventricle, or during the aqueductal stenosis, we can go for the surgeries called aqueductoplasty with aqueductal stenting. And this is the time when we can go for the third ventriculostomy along with aqueductal stenting. Infratentorial cisterns are also important cisterns to release the CSF, to prevent the brain edema. They are unpaired and paired. So unpaired cisterns are interpeduncular cistern, prepontine cistern, premedullary cistern, quadrigeminal cistern, and cisterna magna. And paired cisterns are CP angle cistern and cerebellomedullary cistern. So you can emphasize them from the color atlas of brainstem surgery. What are the clinical implications? So the operative approaches to the cerebellum and fourth ventricle may require splitting the vermis, resection of the part of the hemisphere, removal of the tonsils, depending on the diagnosis. When there is a Chiari malformation, removal, not removal, but if we see the scarring of the tonsils, we can, or during this, some kind of surgeries which cause the hindbrain herniation. So this is the time when we can see the scarring of the tonsils and proceed surgically with them, opening of the inferior medullary velum, separation of tumor from the floor and the roof, dissection of the region of cerebellar peduncles and deep cerebellar nuclei. retraction of removal of the flocculus. And another clinical implication, the common approach to the fourth ventricle by splitting through the vermis of the suboccipital surface. Dandy, long time back, stated that the vermis could be opened in its center to gain the access to the fourth ventricle tumors without causing the disturbance of function, provided the operator carefully avoided the dentate nuclei. Small lesions in the vermis may not cause symptoms or deficit, but the larger lesions of the uvula, nodule, or flocculus involving the cerebellar fibers related to the vestibular system can cause the equilibrity disturbance with the truncal ataxia, staggering gait, oscillation of the head and trunk on the assumption of the erect position without ataxia on voluntary movement of the extremities. Injury of the vestibular projections from the brainstem to flocculonodular lobe also causes the nystagmus that is present in all directions of the gaze. Cerebellar mutism is the transient complication that may appear after the removal of the cerebellar tumors, usually in children, characterized by lack of the speech output in awake patient with intact speech comprehension, sometimes associated with the oropharyngeal apraxia. Although the exact anatomic substance for the mutism remains unknown, but the majority occurred after the removal of the midline tumors involving the vermis. Thank you.
Thank you very much, Dr. Nargiza. I was on the phone with Professor Riyaz Ahmed. Unfortunately, he still had some problems and he was not able to connect. So, Dr. Nargiza was very brief and he gave a very good presentation and very concentrated. If we have any questions from the audience, because I think we still have some time. If any of the audience or participant has any questions for Dr. Nargiza, otherwise we can make questions later if there is no any questions for now. Okay, Dr. Ibrahim Shamhout, he asking about the function of the tonsils, of the cerebellar tonsils.
So, in fact, the tonsils, the function of the tonsils, even though when they are going under the any herniation or under any compression, they don't cause any symptoms. Patient may have any gait disturbance, but most of the time it remains intact unless it goes to some bigger lesions or bigger, let's say, compression.
Well, just to add to it, tonsil is being a part of the flocculonodular lobe, has an action on pursuit movement, particularly when it is supposed to act for the control of eye movements. So it contributes to the smooth pursuit of the eye movements, tracking a moving object, and also for the gaze stabilization. And beside this, Nargiza had already mentioned about its role in herniation syndrome and in Chiari malformation.
Thank you.
I think there is no more questions. Thank you very much, Dr. Nargiza, for your presentation. It was very good and concentrated, and it gave very nice information for our targeted audience, the medical students and the university residents, and very nice information as usual.